I'm Dr. Robert Dude, an assistant professor in obstetrics and gynecology within the division of gynecologic oncology. And today I'm presenting on synchronous uterine and ovarian cancers, misdiagnosed or mistreated. I have no conflicts of interest to declare. Just quickly, because I'm still new around here, just my background and my mentors were here at the University of Pennsylvania for my OBGYN residency as well as my MD degree. And then was at the Anderson Cancer Institute most recently in Houston under Dr. Neil Stood and Karen Liu, and then just started here at the University of Utah Huntsman Cancer Institute in July of last year, working with these great folks and mentors. Background first, we'll start with uterine cancer. It's the most common gynecologic malignancy in women in the United States. The majority of which present usually early at stage 1 when it's confined to the uterus, and of endometrioid histology, which is typically curable with surgery alone with an excellent survival and low risk of recurrence. For advanced stage disease, recurrence is high, however, so adjuvant therapy is needed in these specific cases. Ovarian cancer is the second most common gynecologic malignancy, but rarely diagnosed at early stages, namely 1 when it's confined to the ovary. It's most commonly a serous histology and rarely of endometrioid histology, which is a lower risk type. The majority, therefore, have a high risk of recurrence and receive adjuvant chemotherapy. In 2 to upwards of 20%, however, of uterine cancer cases, depending on the age, a synchronous ovarian cancer can also be found. The majority of these are dual endometrioid histology type. Therefore, most are low stage, low grade, low risk, and oftentimes just observed. However, they do pose a diagnostic challenge. Are synchronous primaries existing of both the ovary and the uterus arising independently? Or could these instead be metastatic uterine cancers that travel from the endometrium to the ovary, which is specifically stage 3A disease shown here in the diagram to the right? This could pose both a diagnostic challenge, but also have repercussions in adjuvant treatment. If misdiagnosis were occurring, we'd expect that we'd see women with synchronous stage 1 primaries with worse survival, closer to a stage 3A uterine cancer, or perhaps we might be overtreating these synchronous low-risk diseases. Therefore, my specific aims of this project, number 1, are to compare the survival of women with synchronous stage 1 cancers of the uterus and ovary to women with stage 3A uterine cancer in the SEER database. My hypothesis being that the women with stage 3A uterine cancer will have a worse overall survival. Next is to compare the survival of women with synchronous stage 1 cancers of the uterus and ovary to women with non-synchronous stage 1 cancers of the uterus or of the ovary. My hypothesis being that women with synchronous stage 1 uterine and ovarian cancers will have a worse survival. The methods for this study first included women in the SEER database from 2004 to 2015 with stage 1 uterine, stage 1 ovarian, and then stage 3A uterine cancers. For those unfamiliar with this data source, SEER is a US-based representative population-based database of patients diagnosed with cancer among the states shown here at the right, of which Utah is a member. The outcomes of this study are that cancer-specific survival in women with stage 1 uterine and ovarian synchronous cancers versus women with stage 3 uterine cancer and versus women with non-synchronous stage 1 uterine or ovarian cancers. We're looking at a number of covariates, namely demographic factors, as well as treatment and diagnostic factors, as well as specific factors to the patient's cancers. Luckily, we attained sufficient N for this study, given the rarity of both this stage as well as this synchronous primaries, but had over 500 women with stage 3A uterine cancers and over 930 women with stage 1 synchronous uterine and ovarian primaries. As is known and has been described in the literature, the women with stage 1 disease, and namely the synchronous stage 1 disease, tended to be younger when compared to the stage 3A uterine cancer patients. Interestingly, Asian and Pacific Islander women tended to be overrepresented in the stage 1 synchronous ovarian and uterine cancer group. and has been described in the stage 3A uterine cancer group. We see that Black women, known to be of worse outcomes and significant health disparity, tended to be overrepresented in this advanced stage group. Looking at the cancers themselves, first and foremost, the stage 1 synchronous cancers, given that they're an early stage, also tended to be of a lower grade 1 disease. And this is, of course, in contrast to the advanced stage 3A cancers tended to be of a higher grade 3 status. Nearly all women received surgery, as expected, given this is a surgically diagnosed and managed disease. And about half of women in the advanced uterine group received either chemotherapy or radiotherapy. About half of the women in the stage 1 synchronous uterine and ovarian cancer group received chemotherapy, and just a minority received radiotherapy. First, looking at overall survival in the synchronous group versus women with stage 3A disease, we do indeed see an expected survival benefit in stage 1 uterine and ovarian synchronous cancers, shown in red when compared to the stage 3A uterine cancers, shown in teal. Next, given, as I had mentioned, age tended to be different between these groups, we wanted to somewhat control for other causes of mortality, and then started looking at just cancer-specific survival. All groups are shown here. First, of note is that the survival benefit in the stage 1 synchronous uterine and ovarian cancer group, shown in purple, was maintained within the cancer-specific survival, as they had improved survival when compared to the stage 3A uterine cancer group, again shown in teal. Of note, the stage 3A uterine cancer group did have somewhat of improved survival when compared to the overall survival, given that this is now just a cancer-specific survival. Now we are looking at the non-synchronous stage 1 ovarian cancer group, shown in red, and the non-synchronous stage 1 uterine cancer group, shown in green. And interestingly here, for the cancer-specific survival for the synchronous stage 1 cancer groups, when compared to these two groups, they had an improved survival, regardless of either uterine or ovarian cancer. We had been concerned that this could be due to confounding by indication, given that these might be lower risk histologies or grades or other factors. So we next restricted the analysis to those receiving any adjuvant therapy, which would likely select for all of the higher risk disease statuses. In the stage 1 synchronous survival, this benefit maintained its improved status. And then the stage 3A synchronous cancers seem to be unchanged, so they didn't really change restricting to this group, and that's because the majority received adjuvant therapy. And then interestingly, just looking at the stage 1 non-synchronous uterine cancer group, shown in green, they did tend to have a worse survival when restricting for the subpopulation of those receiving adjuvant therapy. This is likely simply confounded by indication due to, again, we're selecting for higher risk disease. So my preliminary conclusions on my first cut of this data are that women with stage 3 uterine cancer indeed had a worse survival than women with synchronous stage 1 uterine and ovarian cancers. These trends continued in cancer-specific survival. Women with the stage 1 uterine and ovarian cancers had a better survival than women with non-synchronous stage 1 cancers, regardless of adjuvant treatment. This suggests that misdiagnosis does not occur, given that a group of women with stage 1 synchronous primaries contaminated or misdiagnosed with stage 3 uterine cancers would likely have a worse survival than stage 1 uterine cancers alone, which we did not see. It is, however, important to note that we need to control for age, histology, and grade, given that the restricted analysis for adjuvant therapy doesn't really get to these fine points. Therefore, my future directions are to further investigate the demographic differences, namely in age, race, and ethnicity that I had mentioned, and really explore its interaction with histology, given we know that race and ethnicity and age tends to have increased risk for different higher risk histologies. I then plan to do some adjusted and sub-analyses for age, grade, and stage. And then I also plan to assess if adjuvant treatment is given to appropriate patients, really to explore for overtreatment. I do have some further studies, the first of which is underway, is to investigate tumor level or somatic genomic differences between these cancer groups using the M2Gen platform, which is a whole exome sequencing platform done for our center as well as a consortium of which we're a member. And then further, I plan down the road to investigate family level differences between these cancer groups within the Utah population database. These are my references. And I'd love to extend my great thanks to my co-investigators, my mentors, and my funding sources. Thank you.